health challenges in practice. We're grateful for the participation of the panelists and the other moderators. Everybody's names are up on the board. Sara at the bottom was not able to participate, so she's not here. In the title of our panel is Global Health Challenges are closely linked to challenges of equity, and nowhere is this more apparent than in neglected diseases and situations. This session will explore experience and priorities for health challenges that confront marginalized communities, especially but not exclusively in Africa. So we'll have each panelist, as they go, will introduce themselves, what their current responsibilities and position is, and then they will be speaking about their topic for about 8 minutes. Then we'll have about 5 minutes in between for specific questions to each panelist. And then at the end, hopefully we'll have 15 to 20 minutes for overall questions. So you can bring up things in the middle as we're going. So first my co-moderator here is Karen Moss, who is from Cape Town as well. So each person will introduce as they go.
Sister Zelna. Good afternoon, everyone. It's a great privilege to be here this afternoon, really to share on health challenges in practice. I am the president of the Leadership Conference of Consecrated Life in Southern Africa, so Africa, Botswana, and Eswatini. And I'm also a health professional myself. I'm a qualified nurse. Before I became a religious sister, I was in practice. And when I entered the congregation, I was also in practice on the ground in community health. So the challenges that I'm going to share with you were challenges I also faced when I was on the ground, and they're still persisting, which is very concerning for me, looking back. But as we know, we are here under the auspices of Ubuntu to help each other to find the way forward. And so, with the help of the Catholic Association for Health in Southern Africa, I'm here to present them and to present all the religious clinics, hospitals, organizations that works on the ground that tries to make a difference. We know that all around the world, health inequalities are stark. Diseases we call neglected persist not because they are unpreventable or untreatable, but because they affect those who are often forgotten. Neglected tropical diseases alone still afflict over 1 billion people, mostly vulnerable men, women, and children in undeserved regions. In Africa, we know HIV remains one of the leading causes of death, with nearly 25 million people living with HIV on the continent of over 60% of global infections occurring in this continent. Many among adolescent girls and women. So again, the face of disease are girls and women. Non-communicable diseases like diabetes, heart disease, and cancer are rising rapidly and now account for more than a third of deaths in Africa, often going undiagnosed and untreated due to poor access to no care. Meanwhile, mental health conditions, which are frequently overlooked, affect 1 in 4 people at some point in their lives. Yet, most do not receive treatment, especially in low-income and rural communities. But these illnesses thrive where poverty and exclusion reign, illustrating how closely health challenges are intertwined with social justice. In my role within the faith-based leadership in South Africa, and through my experience at the Catholic Healthcare Association, it is clear that where someone lives, how much they earn, or the stigma they face can determine whether they receive care or fall through the cracks. Our task, in line with the Ubuntu ideal and the UN's Sustainable Development Goals, is to close these gaps through solidarity and action. I'd like to focus now on the few challenges that came about in our discovery. Ladies and gentlemen, marginalized communities in South Africa and beyond continue to face serious barriers to quality healthcare. Let me highlight just a few. Logistics and mobility. For many in rural, informal, and unresourced areas, distance and cost makes accessing health care extremely difficult. The price of transport and the journey to the nearest clinic often leads to delayed or skipped treatments. Even when they arrive, long waiting times at overstretched public facilities test their endurance. And for those who rely on a daily income, spending hours at the clinic often means losing a day's pay or missing income opportunities. Simply put, it is unjust that getting medical help means an arduous day's travel or lining up at dawn. The second challenge, mental health struggles. The mental health, like depression and anxiety, silently undermine physical health care. When someone is struggling with mental illness, they may lose the motivation or courage to seek help for other healthcare needs. In some low-income communities, mental health services are scarce and stigma is high. The poor and most disadvantaged among us are at the greatest risk of mental ill health and least likely to receive care. This leads to a vicious cycle. Untreated mental health issues reduce engagement in treatment programs, and untreated physical illnesses further fuel mental distress. We must break this cycle by treating mental well-being as an integral part of healthcare, not as a luxury. The next challenge is myths and misinformation, and we know that it's quite strong in our communities, where there's a mistrust about healthcare services, where there's myths around diseases, where there's myths around especially the COVID-19 disease that we had, where people did not trust. When it comes to HIV and TB, people have their own cultural thoughts and myths that if I do this, something else will happen to me in my family. Another challenge is stigma. And again, stigma, the fear of judgment from the neighbors, from the peers, from the family members, especially around HIV. Even today in South Africa, when you go to the clinic, it is not always separated. There's always a special line for those who are going for the HIV medication. But can we do an inclusive way of seeing HIV as a chronic disease so that everybody goes through the same door and there's no discrimination? Negative perceptions of health personnel is the last challenge we face, that when our health personnel are overworked and they're not able to de-stress for themselves, how do we help them? Because they treat our patients not as people, but as numbers because of the pressure that they face. In response to these challenges, we have, through faith, 2 innovative actions. The first action is, according to the first challenge, that we bring the clinics to the people. So as the healthcare profession and the healthcare association, we found the gaps between the clinics far from the people, where we had mobile clinics, and we go to the people. when we had the HIV and the COVID vaccine drive, people could not come to the clinics, but we went to the clinics and we supported them. And because they came to the clinics, they did not only get the vaccine for COVID, but they could also get other vaccines at the same time and other health needs. The second challenge that we faced and we tried through innovation was how do we train our personnel to be people-centered and care with compassion. And so we had special trainings for them where we taught them how to treat patients not as numbers, but as people. And to be patient-centered, allow the patient to talk about who they are and what they need. Because many times a patient comes to the clinic not because they're really ill, because they want to talk. So thank you so much for this time, for listening to us, and to listening to us from the healthcare profession, and trying to find a way of how we can see our patients as persons and not only as a disease. Thank you.
So we're going to take some questions now. If anyone has a question they'd like to ask. Do we have to take the mic? There's a question in the back right-hand side. My right, sorry, your left.
Well, first of all, thank you so much for your service. Secondly, I was in a panel yesterday, and one of the things that came up were, and I forget the exact statistics, but sisters were involved in 30% of the hospitals and the Catholic schools, but then they were never invited to policymakers and government officials to actually explain or to share those innovative ideas. So when you're on the ground, you have the best ideas. So how do you, maybe it's a different group, a different country, but how do you actually share those ideas? Do people listen to you? So,
Thank you very much for that very important question. I think through the Catholic Health Association, we try to do advocacy. And by doing advocacy, we try to invite people from the presidency, people from who does the policy making from the health department, to actually be involved in the programs that we do through various activities. And I think by us getting to know them and they coming to the grassroots to actually see the projects, we build that relationship. It's all about relationship building. I always feel that Catholic Health Association is not there to compete against the government, but to fill the gaps and hopefully to bring the government there where we are so that we can move forward and find the other gap that the government hasn't reached yet. And so I think the challenge for us is to keep on advocating, keep on inviting them to these new innovations that we are trying out, and we're finding it's working because the people tell us, thank you for being there and for assisting us because the government hasn't arrived there yet. So thank you for that reminder and the challenge that we should continue to advocate, because sometimes that is the part that's the weakest. We're more hands-on, but the advocacy could be strengthened. Thank you.
Thank you very much for the well comprehensive presentation. I would like to ask, because there are two challenges there that we have got, the myths and misconceptions that you mentioned about diseases of HIV, cancer, etc. And then on the other hand, the nursing staff is distressed because they are being overworked or overwhelmed with work. So what is your recommendation either to policy or to the day-to-day as a profession? Thank you.
Thank you very much for that challenging question. I think my recommendation would be within community to identify those traditional healers, that I would call them, traditional healers and find ways of how we can collaborate together as healthcare workers and traditional healers. Because I do feel there's merit in the traditional healers, there's goodness, they work closely with nature, but is to find the way of how do we collaborate and disseminate the correct information to the people. Through the spirit of Ubuntu, I think working together in solidarity is the way forward. Thank you. So for the policymakers, I know the government already are calling forth the traditional healers to be as part of their discussions. I know they have special meetings for them, but I don't think it's happening on the ground in the communities. I think that's still the divide is still there. And I think for us as the healthcare professional, we should find ways to really call ourselves together and have those meetings more intensely and intentionally. Thank you.
Yeah, thank you, sister, for your presentation and for sharing those thoughts and for your service. I'm Dose Bazira. I come from Georgetown University in the United States. So storytelling dissemination, is one of those tools you can use to elevate your work, because there is a lot of competition for information and for attention. And in our work, Georgetown, as you know, is a Jesuit institution. We know that faith-inspired healthcare systems don't get the level of credit they deserve for the work that they do. And part of it is because they don't tell their story. They don't publish about their work. So have you considered building beyond the advocacy and engagement with policymakers? Have you considered building partnerships with academic institutions in South Africa or other places so that you can work with students, with researchers and faculty members to tell your story in a structured way through more established fora and mediums, so that you get the attention that you deserve for more collaborations for people who are coming in from either the private sector, from government, from the international community. Because unless you tell your story, someone else is gonna tell it for you, and it may not necessarily reflect exactly what you're doing on the ground. Thank you.
Thank you very much for that insight and the input. I think it's very important that we do tell our stories. And I think what's happening now with various funders that we approach, they want us to tell our stories and put it out there on the social media. I know as the Catholic Church, especially the sisters, we're not so good with putting ourselves out there. But because of various funders who demand us to be public, to be transparent, through the Catholic Health Association, we have to have our annual AGM, where it's open on the public now. Before it was in person, now it's via Zoom, which opens it up for anybody to attend and actually see the good work that's being done. So I think even the COVID pandemic kind of broadened our horizon without us even being aware, and pushed us out into the public, where researchers are trying to help us in identifying the works that we need to do in the community. But I think we can always do more. We are working with academics because of research papers we have to do for funders, because they don't just fund, they want to know how did you find out the needs of the community. But yes, I agree with that. The more we tell our story, the better for the whole society. But thank you for that, and we hope we can connect afterwards. Thank you.
Maybe just one more question, and then we'll have to move on to the next panel.
Okay. Sister, thank you very much for sharing. I was just wondering, in your country where there are spaces actually that you are not just taking advantage of, sisters. I'm asking this because I come from Zambia, and I see that, from the SDGs, then, AU agenda, and then at national level, there are national plans, for 5 years in Zambia. And I see that we who are religious and in advocacy or in governance issues, human rights, we actually find ourselves there because of institutions that work. For example, I worked for the Jesuit Center for Theological Reflection. But I wouldn't say sisters or other people that are actually running institutions to find themselves there to influence policy. So I wonder whether you are also consciously taking advantage of spaces if they are there.
The spaces are there. I think there are people who are connected, but maybe we do not have everybody fully engaged into those spaces. As I said, we try to always have the advocacy arm that relates to us not doing the work, but also advocating for the better, so that we can create the policy change that we want to see. It's a slow process, because you have to keep on talking, keep on being present. But yes, we are trying to be at those conversations that is being held. Within the National Plan of South Africa, we try our best to make ourselves known. That's why I was saying we invite our ministers or the people in the health department to actually come and hear. And I must say they have been very gracious in attending meetings. But we can't just stop there. As you are saying, to be challenged to do more and to be actively involved in those platforms where we can visibly make the change and see it happen. Thank you.
Okay. So thank you for those very instructive. I think all over the world, the importance of faith-based medical care and hospital systems are kind of underestimated, the amount of impact that it has everywhere in the world. So thank you for the efforts of Catholic healthcare in South Africa. So we'll now turn the time over to Karen Moss to introduce her topic as well.
Okay, mine's going to be a PowerPoint. Because the thing I'm talking about is very visual, I thought it's useful to just see it if you're not familiar with it. I'm going to stand over here. So my name's Karen Moss, and I'm Executive Director of an organization called STEPS Clubfoot Care, which is based in Cape Town, but we work nationally, and we also work in neighboring countries, mentoring and training. So I'm going to focus on Clubfoot and the challenge of health equity. And, sorry, next slide. I'm not used to having instructions. Okay, so what is Clubfoot? A lot of people don't know what it is, even though it's extremely common. If you look at the numbers of birth conditions, it's one of the highest that there is, especially musculoskeletal. So it's a condition, as you can see in the picture of this baby, that's a newly diagnosed clubfoot at one of the partner clinics that we support. And the numbers are, it's like a shifting scale really, because there isn't really very clear data worldwide on the incidence of clubfoot. So based on studies, it seems to be around 1 in 750 world average, but higher in Southern and East Africa. So STEPS works on 1 in 500 births, which is high. There's one study that says 2 to 3 per 1,000. So I don't know. I said 1 in 100, I meant 1 in 1,000, sorry. 2 per 1,000, 1 in 500. I'm not good at maths. So why is this important? Well, if you don't treat clubfoot, it becomes a permanent disability. You can't wear normal shoes. As we know, most kids in countries with low resources have to walk to school, so you're missing out on your education. And then your ability to have a full life, contributing to the economy, getting married, just, things that we tend to take for granted, but it's not so if someone is living with disability. And the other thing with living in many African countries with disability, there are not really any resources to assist you. Although there are departments in the ministries that are supposed to work with disability, there's many other priorities, and unfortunately, people with disabilities fall way down the list. So it's very important that clubfoot is actually treatable. So it's a preventable disability. This is one of the most important things that we need people to know in terms of advocacy. The child does not have to live with clubfoot, and in fact, it costs the country more for a person to be living with a disability than to treat clubfoot early and effectively. And the way that we do it is through the Ponseti method. So 20 years ago or so, no one really heard of the Ponseti method. Dr. Ponseti was a doctor who was a Spanish immigrant who landed up in Mexico after the Spanish Civil War. And he ended up in Iowa and started researching certain things. He was fascinated by children's musculoskeletal birth conditions. So he studied the anatomy of clubfoot. And he discovered that actually there was a better way of treating clubfoot that didn't involve surgery. So as you can see from here, this is how the Ponseti method works. The child is diagnosed. They then have weekly casts. If you'd like to go and look at the model over there later, it shows you the foot is like this. You then go and gradually the foot turns into an outward position. Because the clubfoot's like this, you get it to that position. And the only invasive thing that's minimally invasive is you using local anesthetic, take a tiny little scalpel, cut into the back of the heel to cut the Achilles tendon. Because clubfoot, all the tendons are very tight and short. And the Achilles tendon is one of the strongest, thickest ones. Takes the longest to stretch. So rather than keeping on casting a baby for months and months, you clip that tendon, put the final cast on, and the baby has straight feet. It's really quite miraculous to see. From this to this in usually 6 to 8 weeks. Then the next phase starts, which is a night brace. There's a couple of considerations there. One from India, which is handmade. We make some of these also up in Gauteng. The Baragwanath Clinic has been making them since 2007. And then a low-cost option that was developed in Iowa as well, the Iowa brace. So what happens with that is the child has to then wear this brace from birth, well, from treatment, so it could be about 3 months old, up until the age of 4. But they don't wear it during the day. So their lives are not compromised at all in terms of mobility. They can run around and play with their friends as toddlers, but they have to sleep with the brace on at night because that is preventing the foot from turning in again. So no one really knows why clubfoot occurs. It's a genetic and environmental based condition, but there's been many people trying to study and still haven't come up with a definitive. I actually saw a study out this week, but I haven't read it, but I'm not a geneticist, but it sounds like they're getting closer. So let's just move on because I think I've got 3 minutes left and I just want to go into a little bit of the point where I get very passionate about clubfoot. So the point is it's treatable. So can we go to the next slide? Okay, so that is, we've already spoken about, but that on the right-hand side is a 4-year-old that was treated at one of the clinics. Often the children are only picked up at early child development centers, and it's a very sad situation that still occurs around South Africa. So, we can carry on to the next slide. A lot of what Sister Zelna said is common to clubfoot as well. Where you're born, it's almost like the lottery. If you're born here, you'll get good treatment. If you're born there, you won't be able to access treatment. The level of your parents' education, the economic strains your family might be living with. So there's not only an emotional problem and stigmatism and being isolated from the community, feeling shame, is that financial consideration. So it's psychological, it's logistical, it's economical to get that child into clinic early. And if you can do the next slide, for Ponseti method, it's really vital to actually get the child treated as quickly as possible. So we developed a model which includes training health professionals, supporting clubfoot clinics, 48 clubfoot clinics around the country in state health, from the biggest Baragwanath hospital down to a tiny little rural hospital in Eastern Cape or clinic. Advocacy, as you so well described, is so important, and it's really so important, not only the stigma, but to raise the awareness that clubfoot is a treatable condition. And then clubfoot braces. This is a huge problem in South Africa. I got a document yesterday, the crisis in Gauteng, because the health budgets are a mess. Everything's getting cut to do other things, and health, unfortunately, is often the victim of that. So it's really important that we, find solutions, and we have managed to find some solutions for clubfoot braces. You can do the next slide. That's our reach across the different clinics that we've got across South Africa. Average impact of what we've achieved, and all started by a mother with no medical experience whatsoever. But it's amazing when you partner with people and you meet people with similar ideas how far it can go. Next slide. I wanted to just talk a little bit about cure because Santhosh is going to give a talk. But when I actually, we don't need to go too much in the statistics because that's going to be part of your talk. If we can go to the next slide, please. And that's his reach. India's got a lot more people than South Africa. It's incredibly impressive what they've achieved in terms of their numbers. But let's go one more slide on because I'm nearly ready to stop. So why I was interested in when I prepared this talk, I realized that we actually had quite a lot in common. Um, unwittingly, we were developing similar programs. So a lot of our work is public health partnerships, health system integration, local training of health workers, free or low-cost provision of clubfoot braces, and family-centered education. So we are proving that locally led programs, not top-down approach, can be incredibly successful, have to be driven by strong champions, strategic partners, and a lot can be achieved. So I'm going to end there because we're running out of time and the next person must come up. Thank you.
Hey, perhaps for a moment, we'll have some questions. If anybody has questions for Karen relating to STEPS in South Africa and what they've been doing. Or Santhosh, if you had anything, comments, etc. Sorry.
Good afternoon. In South Africa, about disabled children, and it is also related to the grants the government is giving to the children. And as much as the health professionals are trying to give health education as to when a mother is pregnant, how to take care of the unborn child, they take advantage also of the disadvantages. For example, don't take alcohol when you are pregnant in the first trimester. They take that because they are looking at the amount allocated. If a child is disabled, they know very well that they are going to get 2,000 and above. And if a child is just normal child, it's 500 rands. So they are targeting, they want the 2,000 rands. That is why the rate of children with disability in South Africa is growing yearly. So what is that we can do in the case of South Africa to change the mindset of those at the childbearing in an age that they should not look at the benefits, but they should look at the right of the children.
Thanks, that's really interesting. I had never really come across that, but obviously I'm not meeting those families. In my experience, once a family knows there's a solution for clubfoot, I would say the majority of them want their child to be able to walk. The first thing the father wants to know is, can the boy play soccer? You know, and the mother wants to know, can the child dance? Because I think ultimately most families, but when you're talking about food on the table, which is your point of the grant, we identified about 18 months ago, a little bit, I think it was during COVID actually, we had the lack of access. We did a 3-month study interviewing caregivers and looking at the barriers. And at the same time that happened, we identified the SASSA grant for care dependency grant, which you can actually use on a temporary basis for them to access treatment during the casting phase of the treatment, and then so you get it in 6-month periods. So they're getting financial support. They're not having to take food off the table to pay for their transport. So we've put together a family resources toolkit for the clinics and families to be able to get that temporary help. So they may not be getting that long-term grant, but they're going to get a child that's going to have far less needs, in the end. And we found that it's been very well received. In fact, the only negative thing has been certain doctors who've said to me, well, how do we know they're going to use the money for that? And I say to them, well, it's not your choice to decide or judge them what they use the money for, but I honestly believe that most families are going to choose that, and we're seeing a big uptake in that. And also we're seeing an increase in kids coming early for treatment, so we believe that some of the advocacy work is working as well. I don't know if that answers your question. Okay.
Any other question? Oops, any other questions? Sorry.
Thank you, presenter. I very much like the models that have come out. My question is, if you have realized that the top-down approach is not that applicable according to your experience, would you think these recommendations would influence policy? Suppose it's India and South Africa. I suppose these recommendations are both from India and South Africa, or they are from India, both cure in India and steps on club care priorities. Can they be of help in influencing policy in terms of training more health workers, partnership, and low cost? Thank you.
Wow, that's a quite a big question, but I think Santhosh can also answer some of that. We have a unique model in South Africa, which I thought was unique until I started to look at Santosh's model and realize that cure is actually very similar. And I think it depends very much on the environment that you're in, because in a lot of Africa, things are run by a top-down health ministry. Very difficult to get that bottom-up approach. So I'm not sure that it can be replicated in that form. However, the model does give you clear pillars of what you should focus on, and it gives government a blueprint of what they should be doing, and perhaps with the assistance of a civil, some kind of organization that will support that. Because I don't believe that the government in most places in Africa, I don't know of any, is able to do this all by themselves. You definitely need the help of an organization, especially with family-centered care. You spoke about the overstressed nurses, and you can't, in a clinic of 90 or 100 children in one morning at Baragwanath, how can you possibly tell all those parents about clubfoot? You can't. So that's, yeah, I think that is a very good question, and there's been lots of debates about this. Should it be top down, bottom up? And it really, I think, depends on the environment you're in. However, the principles stay the same, no matter if you're doing it or government's doing it.
Thank you.
Okay, thank you, Karen. I think all of you need to be aware that Karen has been working on this for, I believe, 20 years or so, and she has really kind of created something that was kind of not being done almost anywhere in the world, and set up a model to be followed throughout Africa and through many other countries. And she's kind of figured out problems and solved them along the way, so which, as you may realize, this is occurring all over the world as well. And the transition to the Ponseti method is happening everywhere, which is why Santhosh and Atula are here. So we'll turn some time over to Atula now, and she'll explain a little bit about her role in Santhosh.
Maybe we can put the previous slide. The one with the India map. Oh, yes. Yeah. Wonderful, wonderful. Now we acknowledge the presence of Guru Krishna ji. So from India, so I think he wanted to be here. And of course, in our culture also, we don't tell the first name. So, Miss Marshall. That's out. So, wonderful. I think probably what we will do is I'll ask Atula to tell what she has been doing, and then I will tell how we changed. Of course, we changed one child at a time, but what we were focusing is to change the way the healthcare system in India was treating children with clubfoot. So, when we were working with each child, we were also trying to actually twist the way the entire health system in India look at children with a clubfoot and children with a disability. So we'll come to that, but I think she will give information on specifically what we did with this clubfoot.
Good afternoon, everyone. My name is Atula, and I work as a program manager for Cure India, working with children born with clubfoot. And today I would like to share a few points on counseling parents of children with disability from different faith background. First of all, I would like to thank our moderator for inviting me to be on this panel. This topic on health is very relevant, and let me share some points from my own experience of counseling thousands of mothers who brought their newborn children and grown-up children with clubfoot. One common factor I saw among all mothers is the level of anxiety and fear because of the visible disability of their children. They were also much depressed because of the social stigma and discrimination they faced within the family and the community. In addition to all these challenges, they also fear for the cost involved in accessing healthcare and quality treatment. As a counselor, our role is to address all these socio, psycho, and economic challenges these parents are in. I would like to share a story. Once, an elderly grandmother brought her granddaughter to our clinic. She's from a very far distant village. She traveled nearly 3 hours by local train and reached our clinic. When she came to us, I was surprised because none of the parents were with her. And when I asked the grandmother, what happened to parents? She said, they don't believe they don't believe that their child would be corrected with this club feet. So I explained about the treatment and encouraged the grandmother to come every week for the casting. So she sincerely came for 6 weeks for serial casting, and the child feet was corrected, and the child underwent a small procedure called tenotomy. And after 3 weeks, we asked her to bring the child for the bracing, to wear a special shoe. On the day of bracing, both the parents, uncle, auntie, and some of the relatives, 7 of them came with so much smiling and excitement face. So, so the child is corrected successfully and she's going to school now. There are 448 designated weekly clubfoot clinics where children with clubfoot reach out for treatment. In each of the clinics or the centers, we have appointed women counselors who start their relationship with each of the mother. During the course of treatment, we intentionally talk about various challenges these mothers go through. Remember, we have created a system where the treatment is provided completely free of cost, including the foot abduction brace that children have to wear for 4 to 5 years. After 16 years of Cure India, 35% of children born with clubfoot are enrolled in one of the 448 weekly clubfoot clinics. Our plan is to enroll 55% of children by 2030. Our role as a counselor is to help parents understand about the long-term treatment. It's not only one time explaining about the treatment, but every time the parents come, we reinforce about the treatment so that there is no missed appointment, there is no dropouts. And the other role of the counselor is also to distribute foot abduction brace to all the parents, to all the children. And as a counselor, we also document about the program, about the treatment. And as a counselor, we also do awareness, to raise awareness about this problem and to bring the child to the nearest clinic. Let me add one more point before I conclude. Among 120,000 children that are in our program, you see parents from different faith background. If you look at a team of 250 counselors, they also represent different faiths. Every day, hundreds of parents from different faiths interact with counselors of different faith background. However, we have built the capacity of our counselors to respect other faith and appreciate other religious feelings. The focus is on encouraging parents to successfully complete their journey with us as the children go through treatment and rehabilitation. Difference in faith and belief is not a hindrance in building a strong relationship. Together, we work towards a world where no child is left without treatment for clubfoot. Thank you.
Do you want to talk first and then we take questions after you, Santhosh?
Yeah, maybe I'll just add a
Okay.
few more points here. So when we created this program 16 years ago, we didn't want to duplicate what was already there. We decided we work only with the public health system. That means to provide care through the hospitals run by the government. The reason, because that's where the economically deprived families access for treatment, any treatment. Because anyone who has, the capacity to pay for healthcare, they have many choices. Whereas these vulnerable communities come to these hospitals. So we thought those centers should become center of excellence. So we started training doctors who are there in the public health system on the Ponseti method. We also found that one reason for this method to fail is the non-availability of the food abduction brace. Because doctors treat them, the feet is corrected, but then these children come back after 6 months telling that, looks like you didn't correct properly, see it has come back. So, because parents do not have the resources to, buy braces. So we made it a point, it is provided, and every center has counselors so that all the questions are answered, because parents come with so many questions, and doctors do not have time to answer all the questions. And of course, the counselors, the coordinators, they also take care of the documentation. So in this process, a beautiful private-public partnership emerged. Cure India as a private partner, and each state government. So every state, there are 29 states, so we have signed agreement with each one of them. So we always call it the government club food program. So it's not our program. So government take all the ownership, they take all the credit, and ultimately, so what we want is a situation where every child born with club food, the guesstimate is around 40,000 children born with club food in India every year. So last few years, if we take 13,000 children go through the Cure India program. So we have come to around 35%, but we can take it. It's only a matter of time and resources. We can double our impact. So what we have seen is, one, we can change the public health system so that the vulnerable communities can access quality care. That's what we learned by doing this. And now, if you look at children with birth defect and development delay, in total, every year, there are 4 million children. Now, looking at what Cure India did, government is asking us, why can't you now take care of other conditions? And we are happy. We're happy. The counselors are now trained how to take care of, for example, child with visual challenge or child with hearing problem. And there are so many children with autism, with cerebral palsy. So same counselors, same hospital, same system. Now we are actually impacting more children. And we are also into disability prevention by enhancing nutrition. I'll not get into all those details, but what we learned is we can change the way a big nation like India look at and treat children with club food. We changed it. Surgery used to be very popular, and only hardly 10% children were accessing that because it's very expensive. So from surgery to non-surgical method, and it's actually it's a real story of change. We're extremely happy with what has happened, and so because we have reduced the surgery, now this facility is available for others to access more care. So thank you so much for your patient hearing.
Thank you. Does anyone have questions about the India program, or any questions for Santhosh or Atula?
Thank you so much for the great work you're doing. I'm very impressed, actually. But my question is do you have partnership with other faith-based projects like the Catholic Church, the Anglican, the Methodist? Because these are the people who work on the ground, who identify immediately after birth that the kid has the club foot or the disability. But if that, I know we talked with you and you have Chai, so I don't know whether South Africa has such a connection, because also where I come from, all the medical practitioners have like a coalition where they talk to each other, especially now since the diseases have been coming, new diseases like COVID and whatever. they have been coming. So coming together as interfaith people, you are able to at least to arrest that problem from birth, because you are the people on the ground. And some people are not aware that there's this intervention that can happen. So that is my question.
I just want to jump in on this question because I didn't even think about this until yesterday when we were talking, because there's always been a drive to get government involved in advocacy. And you don't think about those amazing people working on the ground in interfaith. So this is definitely something, I've been looking for this answer for a long time to get into those. But you know, the crux is to find those people, to have the networks and connections. And this is a great place to do that. So I think it's a very, very good suggestion and something that we will eventually do in South Africa. We haven't until now. Sorry, you can take it. Santhosh, you can answer the question now.
I think that the public health system is reasonably good that we are able to reach out to the maximum. So government gives us 4 things from their side: the healthcare professionals, the treatment material, all the clinic space, and they have beautiful system to identify and refer children. So immediately after birth, we get to know where the child is born with clubfoot or any other disability, birth defect. So what we do in return is train the doctors, so appoint counselors who will make sure that these children come back and complete, distribute braces and other assistive devices, and we document the entire system. Apart from that, the entire network, we have more than 250 trained counselors. All of them are women, because the mothers feel comfortable in our culture to always call and talk. So what happened was, we had this, I'll take 1 minute. We had this volunteers, senior social scientist wanted to do a social impact study of our work. And what they discovered, so they wanted to study whether the Cure India's support has made any change in the lives of these children and their families, because we made it free. So probably they did not fall into financial crisis. So they wanted to study 500 families. They also identified 500 families in the same community to see comparative how they are doing it. Surprising, even for us and also for the researchers, that they found after this long comprehensive study, families where a child with a clubfoot are doing much better. So, simple questions, whether they have a two-wheeler, whether they have a television, whether the other children are going for education. So everywhere it is yes, 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 where there is a child with a clubfoot. Then they thought they should do a study. Maybe it's a wrong information. Maybe it is, so they went inside and found out, because of these women counselors who have built very strong relationship with the family, whenever there is any other health problem, maybe the next one is pregnant or they met with an accident, they always call these people and tell, see, we are coming to hospital. So would you please help? My grandmother need a cataract surgery. So would you please help? So now we have actually growing to a level that we are helping them to access not just clubfoot, not just disability, any health condition. Otherwise, earlier what happens, whenever there is a health crisis, they, out of fear, they think that there's so much of money required to access healthcare, they sell their cattle, or they pledge their land, or they borrow money before they go to hospital. So today they don't do that. So what happened in this last 16 years and this 120,000 families and 200 counselors, and our counselors handle 36 languages in the helpline number, 36 different languages. So what has happened is the study turned out that because of this extended support our counselors gave, and these families are doing much better compared to their other families in the same village. So very exciting. It's so encouraging to see. And so what we learned is we can actually change the system to work in favor of the most vulnerable communities.
Thanks. Is there anyone else who's got a question? Yes, there's one over there. Hang on, wait for the mic.
Yes, many thanks. Very impactful work. And I found I'm from Ghana, CHAG, Christian Aid Association of Ghana. We are also into club food. And I can, I'm inclined to associate with some of the immediate impact. Families have been, restored. Some men divorce their wives because their children have given birth to children with club foot and the rest. I was struck with the issue of partnership or integration with government. We tried to integrate that program with government, but we saw that they have different orientations. The pro-poor ethos was virtually out, and incentives, some of them require incentives. This is really the vulnerable, the marginalized. So my question has to be with, what have been your experiences with integrating the program, the government health system? What are the risks and rewards? I'm asking that because sometimes when you hastily want to integrate the public health system, you can be extinct because of that. And so we are trying to ring-fence this particular program. Of course, we complement government, but there are obvious risks. What has been your experience? Probably we can learn from the experience of integrating the whole club food project that is really pro-poor and the vulnerable, and with a public health system that could be submerged totally with different incentive systems. What have been your experiences with working with government?
See, we don't want to take the credit, but government systems, I think everywhere are almost the same, very difficult to get into. But I still remember 2008, 2009, but we were determined that we should work with the government. One, we took a policy that we do not take money from government. Okay, it's very clear. We do not take money, but we want to work because we want to change the public health system. But if you ask me, the first state where we signed an agreement, it took 18 months for us to get an agreement signed. So I was like this, the government secretariat was my temple. I went there every day. So when people ask me, are you mad? Why are you going there? Why are you waiting there? This is what they ask. Why are you waiting there from morning till evening? I said, I'm waiting here so that these families do not wait in the hospital. Somebody has to do that. And I was lucky to do that. So, but this is 2009, even irrespective of the chief minister being born with a club foot. So I thought it is going to happen very soon, but it took 18 months. So Ponseti method teaches patience. It's not surgical method. You don't put knife. You have to just wait. But 2010, we signed the first agreement. But by 2016, we also learned how to work with the government. By 2016, we signed agreement with all the 29 states. So it takes time. It takes a lot of patience to work with them. 70% of the people in the government, I don't know whether you are recording it, very difficult to work. But there is 20-30% of people who still want to do something good. And it takes time to understand who is that, and then wait for that chance and then get it done. But once we do it, thousands of families get benefit out of it. So we raise funds from other sources to support our team, the assistive devices, training for doctors, documentation, but we rely on the government system because the impact is every day, we get 60, 70 new children added to our program because of this 448 centers we have. Every day, every month, an average 1,000, 1,200 children added to our program. It's not possible if not for the public health system that we are depending on it. Still difficult. After working with them 16 years, still difficult, but we don't consider that difficult. We go prepared that I have to wait there from morning till evening. So it is joy. So.
There's a question over that side. I wanted to say that sometimes it's not always the health ministry. You can look at social development or disability and think more sort of left of field, because it's sometimes not health, and that will actually be more open to that partnership. Yeah.
Being appreciative of your work and being the largest club food program in the world, and with your projection that you have presented to us, by 2030, would you say this is what you have been projecting, or there have been hurdles that made you to achieve, that will make you to achieve the 55%, and what would be your recommendation for 2030 if you have seen how you have been working and achieving? Thank you.
Our original percentage was 70 by 2030 because there is a global movement called Run Free 2030. But COVID slowed down. So we have put 55% as a realistic, achievable goal. And, but I think we will also reach 70. It's only a matter of few more years. So the ultimate goal is not even one child should be left without treatment for clubfoot so that we can eliminate disability from clubfoot, and it is possible. It is possible.
So I had a question about, you've done just a great job looking at the whole ecosystem of this and really building out. So, I mean, I really think the gentleman earlier who asked you a question, I think you should really do your success story and spell it out a little bit more, because it's a great example for all sorts of other things as well, how you've worked on it over time. The one question I had was about the intervention, like digital, you know, sharing some of this knowledge. I saw in your materials where you work with Rotary to do maybe a webinar or something. So it's just increasing the awareness using technology a little bit more for other countries and places you haven't been yet, you know. I mean, so anyway, that was sort of my question on that. And then maybe medical schools. I know you said stay away from, you know, some of the more medical, but I'm just wondering medical schools as well.
Okay, so I just wanted to say that very limited access to education, high, you know, medical education around Africa. We did during COVID, because we kind of just couldn't go into clinics, because we also train health professionals in the Ponseti method. We decided to go and try virtual training. And that led to 3 global webinars, which were hugely attended from other African countries. We weren't expecting that. We thought it was going to be mainly South Africa. We realized the need that there is for this kind of information. Leading on from that, did a Clubfoot Africa conference in November 22, where over 75% of our speakers were either African or based in Africa. And we were talking about real problems, you know, in our locations where we work. And it's funny because it's just adding on to the need. Because then we did some more webinars, and whenever we get the feedback forms, it's like we need more. So we'd like to do another conference somewhere in Africa, possibly South Africa or somewhere else. We don't know that logistically makes sense. And also we're putting together a project where we will have more online resources in studying, learning the Ponseti method theory, and then attending practical workshops. Because, you know, medical healthcare workers are busy. Now you ask them to come and attend a 2-day workshop, you know, it's, should I go to leave? And also 2 days isn't always enough, you know, to get the full, they need mentoring and ongoing. So it's really rethinking this, how does it work in resource restricted settings, right? Santhosh, I think we're on the same page for that, and making it more accessible, and it's empowering, you know, for the morale of health workers, because they arrive in a new Ponseti clinics, like no one's even got time to tell them what's going on. No, there's a foot cast it, you know. There's no one ready to train them. So there's so much to learn in medical school. They can't just, although I'd love them to, they can't just focus the whole time on clubfoot, you know. So they come out with limited knowledge about clubfoot treatment. Although it's in all the South African university curriculum to learn Ponseti, the reality is there's so much else to learn. They need post-grad training. So I'm going to be quiet and just see if, I'm going to hand this over to you, Martin, and see if there's any more questions. And I think we're probably almost ready to wrap up.
Any other questions?
Thank you. I just want to take this opportunity to say thank you to Dr. Santhosh and Karin Moss, and all of you all for telling us about this amazing work that you all doing to elevate the suffering and bring joy and smile onto the younger ones. Just two questions. One is, how you all continue establishing this program? How are you getting your funds? That's number one. Number two, in South Africa, recently that I start noticing, we do have foreigners living here. Some of them, they don't have proper documentation or ID documents and so on. When they get to public health care, they are refused to get them to come in. So how you meet those challenges, the second one. And the third question is, what will be a cost? For example, if someone out in the world would like to sponsor a child, in India, what it will cost for a child to go through the treatment and the period, and what will be the cost here in South Africa? So, you know, why being from the interfaith community, so when we move around, we will share this message. This is what we needed, how we can. First time I came to know about this Catholic healthcare organization. So I'd like to get connect with you. And also from the interfaith community of the Cape Town and from the Western Cape Religious Leaders Forum and the Hindu Association, we wanted to say thank you for opportunity given me to be part of this session. Thank you.
Thank you. I'm going to answer quickly so that Santhosh can answer from his side as well. The first question was, what was it again? I've got the second too. How do we get our funding? Right. So we also don't take money from government, and we have a lot of foundations and high net worth donors. Not a lot, but it's enough to keep us going. But I think to try and get involved where people monthly giving of small amounts, because it costs 2,500 rand for steps to support a child through 4 years of treatment. Bear in mind, we're similar to Santhosh, to Cure, where we're using government facilities, healthcare, practitioners, space, some of the materials, and that's based on our budget is about 2,500 rand. It's slightly less in some centres, slightly more in others. So that equates to about 60 rand a month over 4 years, which is not a lot to ask somebody. That's how much coffee now costs. Coffee's gone up. So yeah, that is the answer to the question. There was a third one, but I've forgotten what it is now. That's it. Yes, per child, over 4 years. So we ask people to, if you donate 2,500 rand, that's supported one child through 4 years of treatment. So, because of the way the treatment works, the first part is much more intense, and then there's less needed as the years go on with checkups and things like that. Typically.
I just want to start this. Maybe I can make a pledge today. I would like to, through the organization that I'm serving now in the Western Cape as a home spiritual center, we would like to sponsor a child.
Thank you very much.
Thank you.
Thank you for your generosity. You've got my details. So
yes, I do have. Thank you so much. Thank you.
I'll hand over to you.
The average cost for us is, maybe if I have to tell in terms of dollars, $150 in India, 150. So same. Okay. So which includes the training that we provide to the doctors, the salary we provide to the counselors, the braces that we distribute for children for 4 to 5 years. So entire cost per child is $150. Yeah. So in Indian rupees, it is 12,000 rupees. Yeah, in Indian rupees. And where do we get the funds? Indirectly, because doctors are government doctors, the clinic space, the treatment material, 55% of our cost is already covered by the government, even though we don't take money. So the rest 45% we get through the Rotary clubs, then individuals, then the corporation. So there is something called Corporate Social Responsibility Fund. So we are eligible to receive funds. So we do not, actually now maybe around 2% of our funds come outside India, come from outside. So 98% of the funds we raise within India through this corporate social responsibility fund, Rotary, and then individuals. Yeah. And but we value the little money we get from parents. We don't charge, it's free, but suddenly they will tell my child is celebrating birthday, we want to donate 100 rupees. So that is also coming, drops. Yeah.
Any other questions?
So that was actually my question a little bit, but the one other thing I was going to suggest, and I did used to work at USAID, and if I had money, I would give you all the money right now, but that has been taken away, and it will probably take 4+ years to come back.
We should have met you 2 years ago.
Another organization that does a lot of this kind of work sometimes, and sometimes innovates, like with the CAS, which I don't know if possible, like with Syria refugees with CAS, is the Lego Foundation. So if you haven't tried them, they might be really interested in this. And the second connection is Rotary, because there's a big Rotary in the U.S. So if we publicize it in the U.S., then they reach out to local Rotaries. There could be pledges. So, I mean, I'll take that home to my Rotary.
Okay, so maybe in conclusion, I can explain that this transition began probably about 1999, 98 or so, and this transition is happening everywhere in the world simultaneously. And you have seen some examples of amazing things that have gone on, but it's going on all over the place. And the prior costs of treatment surgically were much, much higher, making it so that in developing countries, often there were children who did not have the money to have treatment, period, which would have occurred in India and throughout Africa, etc. Karen was just mentioning she thought the prior surgical method, which was the main way of doing this before 2000 or so, was maybe in the 8 times more expensive. And probably similar to that in the United States as well. So there's been a gigantic reduction in costs, but yet the ability to have a normal functioning foot and a child with growing up without disability for their whole life, the value of that and not having the problems of the surgical methods that used to be used had lots of complications. So all of these things have been in process. Interestingly, about 10 to 15 years ago, Ponseti International, which is where this all originated at the University of Iowa, had interactions with USAID and had 3 countrywide programs started, one in Nigeria, one in Pakistan, and one in Peru, to have different examples of different parts of the world as to how they could implement doing this. Some of them did better than others, and often it comes down to, or it has come down to, individuals that were really committed in different countries figuring out the solutions that are local that made it work better. As you are aware, Rotary for 40 or 50 years was focused on polio vaccines and eliminating polio from the earth as one of their missions. And now there is the Rotary Action Group for Clubfoot. So Rotary is doing this in their programs. Santhosh has some interactions with Rotary in India. Central and South America has Rotary doing this pretty much all over the place. There are national programs trying to make this in every country be possible for every child born anywhere in the world. They have been in process for 10 to 15 years, and you see that having these kinds of transitions takes a long time. It takes development, effort, donors, and I think in this meeting where there is interfaith collaboration, all of these different people who have been working on this interact with each other around the world and getting ideas and input from each other and bouncing things off, having conferences, Like the Africa one that Karen talked about affected probably 30 or 40 different countries around the world. Santhosh has done those in the past. They've been done in mainland China, in Russia, all over the place. This is all happening historically, probably really rapidly, but still there are things to get resolved and done. And we're grateful, and I'm for Zelna bringing up a lot of healthcare dilemmas that exist everywhere in the world to different degrees, and how we work together, different faiths. Like you see that Catholic Healthcare Services does amazing things. They're available in the United States. There are other faiths that do healthcare, and all of those working together to help improve the health and life of people throughout the world is important. So we're grateful that you have come to be able to learn about this. We are all very passionate about it and excited to be a part of taking somewhere where you have children born with a disability, and it's amazing you can make it so that they aren't disabled for the rest of their life in like a month and a half. It's kind of like, there's not a lot of things in the world that are like that. So, yes.
I don't have a microphone, but I think one thing that hasn't been emphasized, just one thing that hasn't been emphasized, that Dr. Ponseti's protege, Dr. Ponseti has passed away, but his protege would be Dr. Jose Macondo. He has said that on average, if they do go through surgery, by the time they're 20, they'll need 3 more surgeries, on average. So this is not a conversation about, we hope that with surgery things can work, but that's just the beginning if they have surgery, of more and more and more challenges. Our own son, who was born in 1999, in the same neighborhood with the same doctor, his child friend has an amputated leg. So it's a serious matter, the difference between
So we're grateful
surgery.
that transition is underway, and for these people who've come to give us a great example of the long efforts to be able to get to these kind of great outcomes. So thank you all for coming.